let us begin.
All right. So today's topic for the journal club is hyaluronic acid use for knee osteoarthritis. The way I structured the presentation was sort of an overview of arthritis management first, and then where hyaluronic acid fits into that, and then jumping into the two articles that I reviewed for the journal club. So we'll just whip through this first stuff pretty fast because it's pretty remedial stuff. So osteoarthritis is defined as a degenerative joint disease that results in the breakdown of cartilage and bone. In terms of statistics, it's the second, arthritis-related conditions as a whole are the second most common reason for medical visits. In terms of knee OA specifically, the lifetime risk of suffering from symptomatic knee osteoarthritis is about 45%, so 1 in 2 people. And then 1 out of 11 will have symptoms come up before the age of 60. And then here's an X-ray image of some bad osteoarthritis. You can see the evidence of the joint space narrowing, the osteophyte formation, and the subchondral sclerosis there. In terms of treatment options that we have for osteoarthritis, I kind of organized them from least invasive to most invasive. The least invasive things you can do is modify the activities you're doing. So if it bothers you to do high impact activities like basketball or running, you can advise that the patient change their activities to those with lower impact. So things like swimming, cycling, or elliptical, things that are easier on the knees. We always also recommend weight loss. So even a weight loss decrease in weight of 5 to 10% can have significant symptomatic benefit for patients. Moving up the ladder, physiotherapy would be sort of the next thing, and things you're working on is specifically our range of motion and quadriceps strengthening, and I gave some examples, some exercises here that might be in their exercise programs. So you have things like squats, leg extensions, things like that. In terms of pharmacotherapy, Tylenol and its different formulations, basically you're looking for a maximum of 3 to 4 grams a day, depending on other comorbidities. One of the more benign medications we have for treating osteoarthritis, and it's usually our go-to now, that oral NSAIDs are sort of falling out of favor. That being said, we do still prescribe them for flares of osteoarthritis, so sometimes when people have a flare, we'll prescribe a short course of oral anti-inflammatories. But in terms of the long-term use, they've really fallen out of favor because of GI and hypertension and kidney side effects. But topical NSAIDs have become more popular because you still get that effect to the area with the more superficial joints, so things like hands, knees, feet, it works well for. And you have decreased systemic absorption, which is good. So those ones are being used more frequently. And then there's adjuvant medications, the gabapentinoids, the tricyclic antidepressants, things like that for more chronic pain pictures.
John, just a quick question for you.
Yep.
So in terms of like the NSAIDs and like the short-term use, like, I think most people are comfortable with that in terms of dosing and everything. I was just wondering, with use alongside of PPI, is there any evidence for that like helping to reduce long-term complications if you're using it just short-term here and there, or is it more?
I don't think it's necessary for short-term, like if you do a 2-week course, but again, take the patient's clinical picture to mind. Like if it's an older person, I'll usually go for Vimovo instead of just naproxen. But that's sort of just anecdotal stuff. I don't think there are side effects.
Yeah, I feel like if they have coverage, I definitely do Vimovo a lot, but then I don't often prescribe like pantoprazole on top of.
Yeah. What do you guys think?
Yeah, I mean, you have to take a number of things into consideration, like her background history. They have a history of any kind of gastrointestinal bleeding, any history of any kind of nephropathy, anything like that, and then how they've tolerated non-steroidal anti-inflammatories in the past. Age is a big one. I really shy away from NSAIDs altogether over 65. They have to be in like pretty good health. So those are a few things that I would look at. And then long-term uses, it's not necessarily dose dependent. So when you're taking anti-inflammatories, it's not as straightforward as there's one reason why you get bleeding in the gastrointestinal tract. There's a number of different reasons why you get gastrointestinal bleeding as a result of anti-inflammatories. So it could be a different pathway. So they could be on it for a day, they could be on it for 6 months, and then start to get a bleed. So you do have to be careful with them.
I think when you're talking about that's a good summary of the GI risks, like in terms of like sort of the endothelial dysfunction. I think like basically cardiovascular risk. Like I don't think there's any like, I think when I was thinking about this before, I used to think that naproxen was like somehow more protective against those risks than others, but it seems like with more recent evidence that all of them have the same sort of that type of risk. So just like what Neil was saying and what John was saying, you have to take sort of the whole picture in perspective. With respect to coverage though, like if they don't have coverage but they happen to be a good candidate and you feel like you want to give them the naproxen, then you can just, like I think lansoprazole is covered under ODB. Like you'd use the limited use code 297, and then that will sort of help that get covered if they're a good candidate for that.
Other things that can be helpful are braces. So there are different types of braces, but the one that there's the most evidence for is a medial unloader brace. And that's predominantly when you have unicompartmental, so medial joint osteoarthritis.
Just a little comment on that. So I kind of reviewed those studies because I did my rounds and that was a big part of it. So the only group that it actually showed benefit for in the studies was medial compartment osteoarthritis and medial knee pain and a varus knee. So that's what I tell people, like if you're the ideal candidate, you are the ideal candidate. If not, you might want to try it, but the evidence didn't support the use for anybody except for you needed the varus knee also.
Gotcha. So it was like a very specific patient. And then as we move into sort of more invasive treatments, there's the group of injections, so corticosteroid use. Falling out of favor a little bit more now as we learn sort of about the more long-term side effects of repeat corticosteroid injections. Hyaluronic acid, the topic of this presentation, and PRP, platelet-rich plasma. And then there's different surgical options ultimately for knee osteoarthritis, sort of ranging from less likely to most commonly done here. So this one depends on their alignment as well, the high tibial osteotomy and the distal femoral osteotomy, depending if they have varus or valgus deformity. Then there's the unicompartmental arthroplasty and the total knee arthroplasty.
Can you go back a slide for a second, sorry? So what's missing there? So there's treatment options for knee osteoarthritis. There's actually a couple more that have been shown in the literature. Are you familiar with anything else apart from corticosteroids, hyaluronic acid, or platelet-rich plasma?
Stem cell.
Okay, anything else that's been studied?
Saline.
We'll see using normal saline as a comparison, yeah? Dextrose?
No, but if you look at those studies, saline to me always seems like a reasonable option.
There's always benefit from it.
No, but
It's true.
So not to get
No,
sidetracked,
absolutely,
because
it's very
you're
true.
getting at something else, but
No.
you know that the Singal. So I went to a couple of these talks with the Singal, with whatever, where they're trying to pitch the Singal. I go for the free dinner. They show this slide, right? And it's like at like 26 weeks out, and it's you know, how satisfied are you with the pain reduction at 26 weeks? And the Singal's like 40% better, right? And then you get the HA only or the cortisone only, and they're somewhere in between. And then the saline only group is like 30-something% happier. And I'm like, that's a cost effective, that's the best option on the board unless you have insurance to pay for the HA or the Singal.
So, but you raised an interesting point. The question is, what effect does merely essentially injecting volume into the joint play? And we don't have the answer to that, but there's several different injectables that have been essentially looked at beyond what you have there, yeah, I think that's kind of what I was getting at, is that we don't know the full effect of why it's having benefit. It's probably beyond placebo effect to some extent. And then the question is about repeat injections. But I'll let you.
Okay. So the hyaluronic acid, or HA, it's a polysaccharide member of the glycosaminoglycan family. It makes up a significant component of both the synovial fluid in our knees and joints and articular cartilage. And the idea is that it's trying to restore the viscoelasticity of the synovial fluid and act as a shock absorber. And sometimes how people describe this to patients is sort of acting like a lubricant in the knee or increasing the volume of the fluid. It's supposed to cause an improvement in patients' pain, increase their range of motion, and as more studies come out, there are thoughts that it could even be disease modifying, so decreasing the progression of osteoarthritis. A relatively recent Cochrane review of HA use in knee osteoarthritis found it to be an effective treatment with beneficial effects on pain, function, and subjective patient assessment. The risks that we quote patients are infection, bleeding, allergic reaction to a component of the injection, which is more of a theoretical risk. I've never even heard of it happening. And the cost is the major one, roughly $400 to $500 for these treatments. Some of the names are here. There's also Cingal, which is a combination of hyaluronic acid with corticosteroid. So the first article I looked at was titled The Cost Effectiveness of Different Forms of Intra-Articular Injections for the Treatment of Osteoarthritis of the Knee. It was published in the Journal of Advanced Therapeutics in 2016. And the aim of this study was to compare the cost effectiveness of different hyaluronic acid products and compare that to conventional care and to one another in the study. They performed a cost effectiveness analysis using data from previous RCT, so they didn't actually do the studies of the clinical benefit. They just took those studies, looked at them, and performed a cost effectiveness analysis, which I thought would be interesting to look at because it's a little bit different than the articles we've been talking about before, which are mostly clinical trials. So with cost effectiveness analyses, you get new sort of terminology. One of the big terms is the quality adjusted life year, which is basically a measure of disease burden, and it takes into account both the quality and the quantity of life lived. And perfect health is rated as 1, death is 0, and then the subjective sense of the quality adjusted life year is usually somewhere in between. And then there's also the incremental cost effectiveness ratio, which is the difference between two interventions in terms of their cost divided by the clinical effect that they had. And that's the denominator is usually the quality adjusted life year, but can be other measures as well. So this is the first sort of table in this study, and what they did was they looked at these different trials here for each of the different hyaluronic acid injection formulations, and they came up with a baseline utility score. How they did this was they took patients' pain scores and they converted it to this baseline utility score, where a lower score indicates worse osteoarthritis and a better score indicates better function or better osteoarthritis. And then they looked at that study, and then sort of 6 months post-treatment, they looked at their scores, and then they converted that to a number of quality adjusted life years gained per 6 months of treatment. So as you can see in this table, the one that had the most benefit in terms of quality adjusted life years was the Uflexa. This is just this table here compares their cost, but then they also calculated the cost per treatment of 6 months, which I like that they did that because the cost at baseline can be not too different, but then over 6 months it could be significantly different. So how they did this is they came up with this formula: the cost of the product plus $43. This is in US figures, and that's the initial assessment code, plus the number of injections at $61, which is the cost of a visit with injection, and then plus the cost of conventional care, because all these studies also included conventional care in addition to the hyaluronic acid treatments. And then they came up with the cost per 6 months in the third column there, and then they calculated a cost per quality adjusted life year gained.
Sorry, John, so conventional care is, do you mean like follow-up appointments, or would it be?
No, that included physiotherapy.
Oh, it includes physical.
Yeah,
It was like NSAIDs and like
Yeah.
braces.
exactly.
So any combination of those things
Yeah.
could have been involved, but also, depending on the patient's preference, none of those things could have been involved?
Yeah. Yeah, so it wasn't really standardized between trials because they looked at, that they just came up with a generic amount basically. So they didn't look at each study and come up with, the amount of conventional care in that study. They just kind of gave it a generic amount, so it was equal between the studies.
Okay.
So they came up with that
Yeah,
equation themselves, that wasn't necessarily in the other studies.
yeah.
Right.
Not surprisingly, Euflexa came out on top here as sort of the best cost-effective option. And then they did this sort of comparison between the different hyaluronic acid brands, and again, not surprisingly, Euflexa came out as the most cost-effective option. So that was the main result of their study, that it had the lowest cost-utility ratio. Does anyone have any comments about the study?
Who funded the study?
Yeah, they're all industry funded, or 4 or 5 of them were industry funded.
They were, and then this cost-utility analysis was done by the Euflexa group.
Oh,
I have a
So,
feeling.
not surprisingly.
Yeah.
I didn't choose this study because of its, rigor and unbiased approach. I chose it to look at a bit of a different, cost effectiveness analysis, and that was one of the points, one of the limitations of the study. I'll get to them a bit later, but I thought it was interesting to look at it like that. They tried to quantify the risk-benefit profile, so when you're speaking to patients about hyaluronic acid as a group of medications, not the specific ones, but I think as a group, overall, you can say that they are a cost-effective option if you look at them as a group in this study. Again, it depends on what $500 means to that patient, but you can sort of give them the results of this study and say that that they used a conservative figure here for the dollars per quality adjusted life year. So I thought that was a nice thing they did in the study. The limitations, they made conclusions on clinical efficacy made on the basis of some heavily biased trials. So all those RCTs that they included, 4 of the 5, like Alex said, were industry funded. So I thought the patient populations weren't necessarily the same, and I thought that was important in their outcomes because if you look at this one here, the Euflexa group had a lower baseline utility score. So you could kind of, the ceiling to make a better improvement is higher for that group because they started at a lower point. So I thought that was one of the factors that maybe contributed to this higher number here of quality adjusted life years gained. And you always have to be cautious of the fact that the study was funded by the pharmaceutical company that found it to be the most effective injection.
well, and then I know it wasn't necessarily the question they were trying to answer with the study, but is if you don't include like cortisone or like there's no control group, so it'd be hard for them to do that because they're choosing studies that wasn't the aim of that study either. But if you're trying to figure out what's the most cost effective, maybe the thing that costs $20 compared to 400 shouldn't be in there. But
Agreed. Yeah.
And their comparison could have been anything,
Yeah.
basically.
Yep. For sure. I thought it would be a nice way to bring up sort of another research topic, which is different types of bias. I'm not going to go through all of these because it would take a long time. But basically, bias in the study can come in different forms, so you can have it at different times. Pre-trial bias can come in terms of flawed study design, selection bias for your participants, or channeling bias. I'll talk a little bit more about these two here because they kind of related to this trial. You can have different types of bias during the trial, and then in the second article we talk a little bit about confounding bias. So selection bias is bias during the identification of the study population. So for example, selecting patients with osteoarthritis with a higher degree of functional impairment for a treatment group compared to the controls, which I felt was kind of the case in this first article. Although they didn't, consciously do that, they were comparing against a heterogeneous population with some of the other studies. And then there's also channeling bias, so patient prognostic factors or degree of illness dictate the cohort into which they fall. So let's say they were doing a trial of total knee arthroplasty versus hyaluronic acid. Patients with more severe OA might fall into the total knee replacement group because of the fact that they have more severe osteoarthritis. So that could bias the results potentially as well. The second article that I wanted to discuss was this one. Hyaluronic acid injections are associated with a delay in total knee replacement in patients with knee osteoarthritis. It was published in the journal, or the Public Library of Science in 2015. And the aim of the study was to compare time to total knee replacement in patients who received hyaluronic acid compared to those who did not. So pretty straightforward. The format was a retrospective claim study. So they looked at patients in the entire Pharmetrics Plus database, which was just under 80 million patients, and then they excluded various patients. So they included those who had a total knee replacement, and then they excluded those who were lacking drug records, no diagnosis of osteoarthritis, age under 18, use of hyaluronic acid prior to the osteoarthritis, which I guess they weren't sure why that was done. Yeah, I know. They excluded various inflammatory conditions, so lupus, gout, rheumatoid arthritis, fibromyalgia, hip osteoarthritis, and then they excluded those who had invalid missing data or weren't continuously enrolled in the study. So basically they came down to about 180,000 patients, 50,000 who had hyaluronic acid, and 130 who had not. The results of the study showed that getting a course of hyaluronic acid injections significantly delayed total knee replacement. So the median time to knee was 114 days from diagnosis to total knee for those who didn't have HA, and it was 484 days for those who received HA. And then they also documented sort of a suggestion of a dose-response relationship where more courses of hyaluronic acid treatment were associated with a longer time to total knee replacement.
Did they say, I'm not sure to read the study, but did they say like what their like those patients that weren't given hyaluronic acid, like what their the different baseline of the severity of the osteoarthritis?
They didn't.
Diagnosis?
No, and that's one of the things that I think might have confounded these results. Patients who with severe end-stage osteoarthritis aren't going to get suggestions for more conservative treatments. They're going to get a referral to a surgeon. Those with mild or moderate osteoarthritis might get more of these treatments, so agreed.
But, sorry, I didn't read the articles. Is it retrospective or like
Retrospective, yeah.
I mean, the other possible thing is like the people who found a doctor who wanted to try HA injections before, it's going to delay before they send them to a surgeon just because they're doing something else. And you might, you go to a doctor whose reflex is to send you to the orthopedic surgeon right away, then they have the possibility of going to knee replacement right away.
Yeah, for sure. Yeah, and I think the patient's preference as well, right? So if it's like a patient who absolutely wants to try everything before going to surgery, then they're going to get more courses of HA and put off surgery as long as possible. And it doesn't necessarily say that the HA has an effect. It's just that's how they wanted to go about their treatment course.
Did those patients that didn't get HA, did they get anything else? Like did they get steroids or
They
any other
did.
type of injection?
So
No.
perfect segue. Planted question. Yeah. So the columns on the left here are those who had HA, and the column on the right here is those with no HA. So as you can see, the patients who did get HA, their use was also higher for corticosteroids. It was also higher for NSAIDs, and it was also higher for opioids. Yeah, those were the main ones. Yeah.
So sorry, 40,000 of the 50,000 HA patients were on opiates. You said the columns on the right
Non-HA, right?
are non-HA? or HA?
Non-HA. So that's 40,000
Oh, that's
up to
non-HA.
130,000.
Okay.
Yeah.
Still, that's still pretty high. That's
Yeah.
about 20. That's about 4. Was it that? Is it 17 to 50?
40
it's
out of
about,
what?
It's about 40. Just under 40% were prescribed opiates.
Yeah.
For
Well,
knee
the
osteoarthritis.
Northern Ontario.
percentages are comparable though, like if you look at the HA, it's
Still
35%.
35%, yeah.
I mean, that's
Sure.
still pretty high.
Yeah.
That's kind of insane.
And that's not being on opioids chronically, but they've tried a course of opiates. I agree. But I know,
Wow.
yeah, still.
Yeah.
It's why they're in a lot of pain.
Yeah. So what I got from this is that they were more likely to try other non-operative treatments as well, the patients with HA. And this was the graph where they showed, so the non-HA cohort, the median time to surgery was 114 days. The HA cohort, like median of 484 between all of them, but then with one course, 386. And then as they had more courses, longer median time to surgery there. So, I mean, you guys already brought up a lot of the key points I had about this study. In terms of its strengths, I thought that it was a very powerful study, large patient population, which gave some pretty good data. I think they tried to show a dose-response relationship, which was, good idea. It's a clear, relevant outcome measure, so you can counsel your patients based on time to knee replacement, or you think this will prolong the time it takes to get to knee replacement, which is useful clinically. And they actually had a plausible mechanism for a cause and effect relationship in this case. So I think it adds to the growing body of literature that for HA and knee osteoarthritis. In terms of the limitations, I think there was definitely the possibility of confounding bias. And I think the other things, like you guys mentioned, that could have contributed were the degree of osteoarthritis at diagnosis. So perhaps those with more mild osteoarthritis were offered HA. Perhaps the physician's practice influenced it, or perhaps the patient's willingness to have surgery could have explained these findings.